So a very good afternoon to everyone watching us from across the globe. On this auspicious occasion, I would first like to wish everyone happy Ganesh Chaturthi. We are gathered here for a webinar on cervical cancer. Is not talked about much. So with us is our speaker for the afternoon, Dr. Sanjeev Kumar Mishra, consultant radiation oncologist, Utkal Hospitals, Bhubaneshwar. Sir, we welcome you to the webinar. We would like you to start greeting the audience and start your presentation. Over to you,
Yeah.
sir.
Good afternoon, everybody. Am I audible?
Yes,
I
sir.
think I'm audible. Okay. So, very interesting topic. People never talk about it. So, we will discuss today about cancer cervix. Being a radiation oncologist, I will concentrate more on the radiation part rather than the other part. But the other part also we are going to cover superficially. Please put on the slide. Yeah. So, cancer cervix, people never talk about it much, or it has been not discussed much. The basic reason is, if you see, the incidence among the people or the low socioeconomic group of people is decreasing day by day because of improving hygiene, vaccines, and other things. It's more we see in the rural women rather than the urban women. So female never talk about this actually. And those who are having multiple sex partner and HPV infection is more among them, they are more prone for suffering about this cancer. That is why they keep it secret. So usually people never discuss about this. And on the other hand, most of the time these patients they come to the oncology department in an advanced stage, and at the same time what we find is radiotherapy is the mainstay of treatment, and most of the time the other branches doctor they think, yes, it is a radiosensitive tumor, send it to the radiation oncology department, let them take care of that. So people never discuss about it, what is to be done, whether to give 50 gray or 40 gray, or because regarding radiotherapy, the other branches people are not very much aware about it. So that is the reason why it is being not discussed much. This is one spectrum of cancer not discussed much. At the same time, if you look at the incidences, it is around 13 per 1 lakh women globally. And in India, if you see, it's around 23 to 4% like this. So it is varied. Maybe it is highest in Mizoram, the 23 per 1 lakh population or 1 lakh female. At the same time, in Dibrugarh district, it is around 4.9%, 9 in 1 lakh population. So again, the incidence varied, especially in India also. If you see, the real thing is it's coming around 23 to 4% varied, because India is having a heterogeneous populated group. The lifestyle of southern part is different than that of the northern part, than that of the northeast part. The socio-cultural difference is also there, because it's a disease linked with that also. So that's why we get this thing. Now come to the risk factors. Risk factor, usually most commonly we find it in the low socioeconomic status people. HPV infection is more. Those who are having early marriage, young age at the first quarters, multiple sexual partners of the spouse. That's very important also. And those who are having multiple childbirth. Smoking is also related to cervical cancer. Many a time a question arises, how come smoking is related to the cervical cancer? The way it is related to renal cell carcinoma or the kidney cancer, it is the same way it is related to that. So the scientists believe that some sort of tobacco products are secreted in the cervical mucus, and this damages the DNA of the cervical cell, which may causes cancer, or which there is a genetic changes causing cancer. And also at the same time, the local immunity is decreased, so that it is more prone for infected by the HPV or human papilloma virus. So that is why indirectly smoking is one factor that also favor the infection of HPV leading to cancer of the cervix. So another important thing, usually we find these cancers among the age group of around 35 to 45, young childbearing age group, average is around 50. So the common presentation, you can see here the anatomy of cervix. Here you can see the cervix, the uterus, uterine body, tube, and at the same time you can see the vagina. So this is the cervical mucosa, and this common columnar junction is here, somewhere here. So that's the real area where we get a cervical cancer. It started from here. We are talking today about the squamous cell carcinoma of cervix. So that's why from there it infiltrate into the stroma, cervical stroma, maybe superiorly going towards the uterine body, maybe inferior to the vaginal mucosa and the upper third or lower third of vagina. So usually they present, since it is in the reproductive age group of the patient of these females, usual presentation we see in a young lady of a postcoital bleeding or irregular menstrual bleeding or intermenstrual bleeding. So usual presentation is most commonly the intermenstrual bleeding or a postcoital bleeding. So that is why early postcoital bleeding, usually you should suspect maybe there is a malignancy. So we should evaluate for those for cancer cervix. So now let us see, when a cancer cervix patient comes to us, what exactly we do clinically. Whenever, see, usually they never come directly to the oncologist, usually they come to the gynecologist or come to the local doctor or local physician, then they refer back to the oncologist. Probably there is some sort of cancer cervix or something is there. And that is why probably when the first doctor who is seeing should evaluate the patient, should do a at least a speculum examination or a pervaginal examination. At least he can suspect. But what happened most of the time, by the time they reach us, they are at an advanced stage. Very rarely we see a early cancer cervix or early stage cancer cervix. So whenever this patient come to us, we do we take a history, we do a clinical physical examination, and the routine blood test of CBC, RFT, or the renal function test, or the liver function test, and HIV. Important thing, what we need to do a biopsy. We do a punch biopsy commonly when there is a big growth. Sometimes colposcopy guided, so many the logulin coated and taking biopsy. All these things are there. I'm not going in detail about it, but usually we take a biopsy from there. And if it is an early stage disease or if it is an advanced disease, like any if we plan for a surgery, then we should go for a EUA or examination under anesthesia to stage the disease and find whether it is resectable or operable or not. Cystoscopy and proctoscopy to look into the rectal invasion or a bladder invasion should be done in all cases of beyond stage 1 or stage 1B3. Any tumor of 4 centimeter size or more than that, beyond that, we should go for a cystoscopy or proctoscopy, because there the tumor probability of the bladder or the rectal mucosal infiltration is there. So that's why you should go for that. And very important thing is the imaging. What exactly imaging we should do, I will just discuss after the next slide. And smoking cessation counseling is a very important thing, because since I told you the smoking is also related to this cervical cancer. So that is why what we need to do is, they are the patients, we should counsel them for smoking cessation, because he may get cured of his cancer cervix but will develop a cancer of the lung due to smoking. So that is why we need to look into that. Now come to the imaging part. Let us see what imaging we do. Whatever imaging, whether it is a non-fertility sparing surgery or a fertility sparing surgery, whatever it is, more or less the same for both the thing. The only thing, when there is a valuable pregnancy with a CA cervix early stage, if you are suspecting a CA cervix, you need to evaluate. There only we try to avoid this scan based on the X-ray, like CT scan, PET scan, or this thing. But sometimes also we avoid MRI, because MRI also causes some sort of noise, some sort of fearness, claustrophobia kind of thing. It may lead to abortion also. So that is why we try to avoid. Maybe in such cases, what we can do is we can go for a US transvaginal ultrasonography. We can go for that. Other than that, if it is a non-fertility sparing, then pelvic MRI is there. You should go for pelvic MRI to know the extent of the disease, which contrast you should do earlier. For metastatic workup, usually we do a chest X-ray, but if there is suspicion in the chest X-ray, you can go for a CT thorax plane. But the preferred modality of investigation for cancer cervix greater than stage 1B1 is the PET CT scan. Very important thing I would like to highlight it. It is not that PET CT scan is required always. You can go for a ultrasonography of abdomen, and you can go for a X-ray chest. But very interesting, very categorically and clearly it has been discussed in the NCCN guideline. The preferred modality is PET CT scan because it gives additional extra information about the nodal status, metastatic disease, and other thing, which may change your total treatment protocol. So that is why the preferred modality is PET CT scan, definitely. But that does not mean that if you have done a CT scan, abdomen, pelvis, and thorax is inferior. It is no way inferior also. But preferred modality is PET CT scan. So most of the time, what happened, many times the oncologist, as an oncologist, we see cases where somebody has done a hysterectomy in the periphery, maybe thinking that probably it is a prolapse uterus, or probably they operated for a DUB. Then incidentally they sent it for biopsy. They found that yes, it is a case of cancer cervix. So then they send it to the oncologist. In such cases, PET CT scan is a really very helpful and valuable investigation. You can go for directly PET CT scan and look into the metastatic disease or look into the nodal status. Also, you can find the local residual disease. Many times people operate kind of stage 3 disease also. So that is why PET CT is very helpful in such cases. But if you are thinking of a second surgery after a hysterectomy, then you should go for a pelvic MRI to look into the residual disease in the pelvis, and you should, along with that, you should go for a PET CT scan to look into the distant metastatic disease, so that you can go for a resurgery or second surgery if required at all. So that's the thing. For fertility sparing, as I told you earlier, you can go for a transvaginal sonography or a pelvic MRI. You can do it, but where MRI is contraindicated, you can go for a transvaginal sonography. For stage 2 and stage 4, stage 2 to stage 4A, whatever it is, directly you can go for a PET CT scan. That is the only modality which can give you all answer. You can start the treatment taking a biopsy and a PET CT scan. No third investigation is required in such cases. So that's all about the investigation and the initial workup, as I discussed. So after an initial workup, doing all the investigation, usually we stage the disease. But if you look at the staging of cancer cervix, you ask anybody, any of the senior colleagues especially, they will answer like this, because it is CA cervix, FIGO is the answer. FIGO staging. People know about FIGO only. TNM staging is something rarely used nowadays also, even in this case, in these days also. Still, FIGO is the gold standard for cancer cervix staging. And the first FIGO staging was done in 1995. That was a clinical staging, basically. So later on, clinical staging means whether it is confined to the cervix is the stage 1, beyond cervix, not up to the lateral pelvic wall, is the stage 2, and up to lateral pelvic wall is stage 3, and beyond the pelvis is stage 4. More or less like that only, grossly, as you can call. So later on, what happened? Few investigations are being inserted into that, pathological and radiological and both clinical. The recent system is like both pathological, radiological, and the clinical. So previous modification last was done in 2009. Then the latest one is in the 2018, around 2 years back. Very interestingly, 2 years back, they have done it very meticulously. Few pathological things has been given. As I told earlier in the first few slides, I show you how it is infiltrating into cervical stroma, and the depth of the cervical stroma infiltration is also a prognostic thing, and also it is the stage is done in that way. If it is less than 3 millimeter depth, it is stage 1A and 1A2 is 3 to 5 millimeter or equal to less than 5 millimeter, more than 3 millimeter equal to, so like that only. Stage 1B is again, it was earlier B1 and B2. Now there is another new thing that has come, is the B3. B3 size more than 4 centimeter. So there are few of the modifications in the staging system in the latest 2018 FIGO staging. Again, stage 2 is like this. Stage 2A1 size less than 5 centimeter in greater dimension. Stage A2 is more than 4 centimeter greater dimension. So these are few of the modifications, few of the changes that is there in the FIGO staging. Earlier stage 3 was stage 3A and stage 3B. Now there is a new thing that has come, is stage 3C. C is C1 and C2. C1 is pelvic lymph node, metastasis to pelvic lymph node. C2 is metastatic to paraortic lymph node. Earlier it was not there mentioned in the FIGO staging. Stage 4 is more or less the same as it was there earlier. Maybe around stage 4A is the spread to the adjacent structure like bladder and rectum, and 4B is distant spread. So this is the one that earlier staging, like stage 1, stage 2, and stage 3, and this is stage 4 rectal involvement. 4A, 4B is the distant metastasis. You can see here. So very interesting thing. Even after 60, 70 year also the same staging system is followed. Only little bit modifications are there. As I told, in stage 1 is the B3 is the new thing. Stage 3 is the stage 3C is the new thing. So these are the few of the new thing. So basically, to conclude the FIGO staging, new FIGO staging is the modern imaging thing has been inserted into that. So that's the new thing in that staging. So now come to the treatment part. So treatment part, I can tell you, like the early stage, usually resectable surgery is the mainstay of treatment, with or without radiotherapy or adjuvant radiotherapy. In between is the CTRT, where stage 2A onward up to stage 4A or stage 3 is the CTRT or chemoradiation is the answer. It's a very simple thing, but new things that has come up, we'll discuss about it. Let us look into the stage 1 fertility sparing surgery, because a young lady really having a valuable pregnancy, or she needs a pregnancy, at the same time suffering from a cancer cervix early stage, stage 1A, no LVI on biopsy. So if you have done a cone biopsy, you take out a cone tissue in the cervix with negative margin at least 3 mm clearance. There the patient, maybe you can put on surveillance, you can observe the patient, no need of further treatment, you can observe. Because you need a fertility in such patient, you need pregnancy in such cases. So radiation is contraindicated in these cases. So if you are getting a positive margin in the cone biopsy, then you can repeat the cone biopsy, or then or you can go for a trachelectomy, radical trachelectomy. I will discuss what exactly a radical trachelectomy, where I can show you here the radical trachelectomy. What happened? We take out the cervix, upper vagina with the surrounding tissue. At the same time, we do a lymph node dissection. The lymph nodes are removed. The ovary is intact, uterus is intact. We never remove it, but it is not an appropriate treatment for cancer cervix. We are doing it to preserve fertility only. That's very important. We are doing it to preserve fertility only. That's very, very, very important. So that is why, as I told you, in stage 1A1, early stage, 3 mm depth of infiltration of the disease. Size is not a matter nowadays. So if you are getting negative margin, just do a cone biopsy, observe, let us see what is happening. If getting a positive margin, repeat the cone biopsy or do a radical trachelectomy. At the same time, simple trachelectomy. At the same time, stage 1A1 with LVI or stage 1A2, the same treatment like that of the thing, but the lymph node dissection is there, or a radical trachelectomy is done with pelvic lymph node dissection. So that's the thing, because stage 1A2 with LVSI, the chances of lymph node involvement is there. In the other one, 1A1, lymph node dissection is not required. You can do a trachelectomy only. In a stage 1B1 and selected stage 1B2, radical trachelectomy or pelvic lymph node dissection with para-aortic sampling. Again, when it becomes B2, B2 is around size, that depends on the size of the primary tumor in the cervix. So there you can go for a pelvic lymph node dissection along with a para-aortic dissection, or a sentinel lymph node sampling should be done, because the chances of para-aortic involvement still is there. But interestingly, again, I am telling you, these treatments are not the standard treatment. These are only for fertility sparing. Very important. It's only for fertility sparing. So that is why we do such of to preserving the uterine function, uterus, ovary, we preserve. That's the conization. You can see how the cone shaped tissue is removed from the cervix. Usually, as I showed you in the first image, the cancer cervix starts from this columnar junction here in the just at the margin of the cervix only, on the os only. Okay. So now come to the stage 1 non-fertility sparing. Non-fertility sparing, the stage 1A, if there is no LVI, it's fine, the same. Or if operable, maybe you can go for an extrafacial hysterectomy. No need to do a cone biopsy and observe. You can go for an extrafacial hysterectomy. If you are getting a positive margin, then repeat cone biopsy to exclude whether it is A2 or 1B1 or a extrafacial or a modified radical hysterectomy with pelvic lymph node dissection should be done if you are getting a positive margin, in spite of being it is in the stage 1A1. So there only we do a extrafacial hysterectomy or a modified radical hysterectomy. Stage 1A1 with LVI, when the LVI is present, you can go for a modified radical hysterectomy with lymph node dissection, or there you can give radiotherapy, pelvic radiotherapy followed by brachytherapy, because here you don't need a fertility. You can do you can radically treat with radical radiotherapy. I can tell you the thing now is, in early stage cancer cervix, if you are operating the patient with or without radiotherapy, or if you are giving a radical radiotherapy in such patient, there is not much difference in the survival, other than few of the things like long-term radiation-related complications are the important factor. That is why routinely we do not prefer for a radical radiotherapy. That's very important. Otherwise, the survivals are more or less the same. So stage 1B1 and selected stage 1B2, again the modified radical hysterectomy with pelvic lymph node dissection with para-aortic sampling, or again the same thing, you can go for a pelvic radiotherapy or CTRT with followed by brachytherapy. So you will get the same result. Again, the stage 1B3, size more than 4 centimeter, and stage 1A2, these are bulky disease basically, but again these are very well confined disease. 1B3 is stage 1 confined to the cervix, stage 2 is little bit of extensive disease, but at the same time these are bulky disease. So here you can go for a CTRT, chemotherapy plus radiation with a brachytherapy, or a radical hysterectomy if feasible, followed by pelvic lymph node and para-aortic lymph node dissection. Or sometimes people do a CTRT followed by brachytherapy followed by adjuvant hysterectomy. Usually this the third one where the surgeon never like to do this thing. People used to do that because after CTRT brachytherapy, they do a PET scan. If they are getting some sort of uptake suspicious of disease, probably that is why it may come out later on as a recurrent disease in the central area. They prefer to do a hysterectomy. Maybe sometimes we prefer, but the surgeons never prefer to do a surgery after radiotherapy. So after surgery, very important thing, if you are planning for a surgery, it's ideal to plan for a surgery who are the patient who need radiotherapy after surgery. If you are giving radiotherapy after surgery, it is rather better not to operate, give radical radiotherapy rather than giving radiotherapy later on. So that is why what we do is we try to find out, is there any indication for radiotherapy post-operatively? If it is indication for radiotherapy is there, then treat it with radiotherapy from the beginning. Don't operate such cases. Because if you are operating such cases and post-operative radiotherapy you are giving, the problem is that when the uterus and the ovary and the other adnexus were removed, all the small intestine will be falling on the pelvic floor and the below down. So that while treating the pelvis, you are going to irradiate more volume of bowel, causing more bowel related acute and late toxicity. That is very important. So that is why if or not if operable but need radiotherapy, it's better to treat with only radiotherapy. So that is the important thing, or important thing to know. So indication for adjuvant radiotherapy after, these are the early stages after surgery. What are the indication? Indication is if you are getting a negative node, negative margin, negative parametrium, then don't give anything. You can observe. But radiotherapy is given when there is a stromal invasion, when you are getting a LVI positive, when you are getting a size more than 4 centimeter. That's a very important. Sometimes we give it in a endocervical growth, we give post-operative radiotherapy. Node positive disease or margin positive disease or a parametrial margin positive disease, we treat it with CT-RT followed by brachytherapy. And if you are getting a paraortic node positive in a surgical sampling, when do a paraortic sampling, then these are the ideal case for to treat like extended field radiotherapy with chemotherapy followed by brachytherapy. But once you are getting a paraortic node positive, it is non-early disease, it is a stage 3C disease. So that is why in such cases what happened, if you are doing a PET CT in the beginning preoperatively as a part of metastatic workup, then definitely you are going to get an uptake in the paraortic area. Then these are the patient better not to operate rather than give extended field radiotherapy, treating the pelvic lymph node, paraortic lymph node along with brachytherapy with concurrent chemotherapy. That is the ideal treatment. But many a times what happened, if you are doing operating a case, doing a paraortic lymphadenectomy, thinking that it's an early stage disease, and if you are getting positive in the node, it is unfortunate because you could have avoided surgery in such cases. So that's all about the stage 1, B1, B2 disease. Beyond B2, stage 1, B3, size more than 4 centimeter, and 2A, 2, and this 2B, 3, and 4A, all these stages disease, the imaging or the surgical staging, if you are getting a node positive, then you treat with CTRT, don't go for surgery in such cases, as already I have discussed. In a imaging or the surgical staging, if you are getting a negative node also in these stages disease, these advanced stages disease, it is better to treat with CTRT followed by brachytherapy. So these are the surgical part I just really discussed, which is not my domain. Just within next 10 minutes, we are going to discuss about radiotherapy. Radiotherapy, it's very important thing nowadays. We do have linear accelerator. We are treating precisely with focused way to the area which need to be addressed. But at the same time, we are the person also, we have treated these patients into cobalt, and we have got survival also. But at the same time, we have added toxicity to the patient. There, the patient after 10 years coming with a subcutaneous fibrosis like feature, at the same time, and they are cured of the disease. So sometimes somebody is coming with a bleeding from the rectum or bleeding from the bladder. At the same time, there is a cure. So cure is there. The cure is always more or less linked to the toxicity. The newer radiotherapeutic technique like 3D CRT, IMRT, IGRT, and the newer brachytherapy technique, the intention of these treatments is to get the best of the best response, survival, at the same time less toxicity. That's very important, is less toxicity. And toxicity is always given by not only the external beam radiotherapy but also by the brachytherapy. So that is why it's very important that you need to do a radiotherapy nowadays. Standard of care is a CT based radiotherapy planning. Ideally it should be a IMRT with a image guidance, or it is called a IGRT, image guided radiotherapy. It should be the standard of care. I am not telling that you don't go for 3D CRT, don't treat in cobalt, but in 2020, at least I would like to tell you should not go for this thing. You should go for a image guided radiotherapy or a IMRT with image guidance. So for that, you need to delineate the target. Where is your target? And for better delineation of the target, MRI of the pelvis is the best modality. So you can fuse the CT and MRI over that. You can fuse the CT over the PET at the same time, because this PET CT is one which can give better idea about the nodal delineation. Where is the node? How is the size of the node? what other nodes are there, whether it is there in the parotid area or beyond that, you can find out actually. But again, definitely, I would, as a newer, as a advanced, like newer radiation oncologist, I would prefer to suggest about the IGRT for cancer cervix treatment. But at the same time, few things I would like to tell you: do not go for that. Like, see, mind it, brachytherapy is again it is a kind of therapy where precisely we give really very high dose. But never ever brachytherapy has been replaced by external beam radiotherapy, either IMRT, IGRT, or even SBRT. People talk about stereotactic body radiotherapy. Never ever brachytherapy, the SBRT or IMRT or IGRT, they are not at all a replacement for brachytherapy. Brachytherapy is the choice where there is indication. You cannot replace it with SBRT or radiosurgery or something else. So these are the things we must know about it. Sometimes treating the pelvis, along with that, we give some sort of more dose to the parametrial gross disease, maybe 5-10 gray extra we give, where there is a gross residual disease in the parametrium. Sometimes we treat to escalate the dose. And usually the optimal results in radiotherapy in cancer cervix we get if we have completed whole of the external beam radiotherapy along with the brachytherapy within 8 weeks. That is very important. It has been seen in the trials that if you are completing the treatment or finishing the treatment within 8 weeks, then definitely you are going to get the best result out of that. So chemotherapy single agents, cisplatin or carboplatin concurrent weekly, we use, and both the platinum compound gives more or less the same result. Somebody who is not tolerating cisplatin, you can go for a carboplatin along with radiotherapy where it is required. So if you see the history of radiation oncology, started from a 4-field radiotherapy in a square set field, a 2D radiotherapy since 1960 to by 90 there is IMRT, now the IGRT. So there is a precision improvement in the precision of treatment in radiotherapy, starting from a 4-field radiotherapy to a multi-leaf collimator radiotherapy. So that is why people used to they used to use the this IMRT, IGRT, and all the newer techniques. So for that, actually, you need to know where the node resides. What is the situation, or what is the place of the node? You need to know this is the position of the node. I need to contour it. I need to mark it, because the newer radiotherapy technique, as I told you earlier, just I will show you a few of the slide. Here you can see these are the vessels. These are the vessel. Surrounding the vessel around 7 millimeter area, you will get the nodes. You will get the nodes in these areas. So that is why, very interestingly, you can see these are the nodes in the pelvic area. These are the nodes in the pelvic area. You can find these are the nodal area. These are the nodal area. So that is why this is the parametrium. These are the obturator node, external iliac node. This is the external iliac node. This is the internal iliac node, obturator node. So you can see here. So usually what happened earlier, we used to treat the whole of the pelvis, whole of the small intestine used to get irradiated at the same time. Here we now need to treat this area only. So for treating this much of area in a telecoupled unit or in a 2D radiotherapy, we used to treat whole of the pelvic area, whole of the small bowel used to get the same dose of radiotherapy as that of the nodal area. So that is why, as I told you, precisely you can treat this area, but at the same time you must know which area you need to give radiotherapy. You must know about the nodal station. So that is why you need to recognize the vessel. You need to recognize the surrounding area in the vessel. Here you can see this is the common iliac vessels. Common iliac, external iliac. This is external iliac, internal iliac, and this is the common iliac. This is the parotid area. So along these vessels, you will find the nodes. You will find the nodes. So that is why, while treating, what should be your target? Like if you have an intact cervix, say cervix 3V, up to lateral pelvic wall infiltration is there. Your gross target, as I can tell you, is these are the nodes. You need to contour these nodes. You need to contour this whole of the uterus, the parametrium up to lateral pelvic wall, part of vagina, upper 1/3. At least you should take 2 to 3 centimeter margin from the vagina. So these are the things you need to know while before doing this corporal radiotherapy. So the target volume should cover the gross disease if present, parametrium, uterosacral ligament, sufficient vaginal margin from the gross disease at least 3 centimeter, presacral node and other nodal volumes at risk. So these are the things you need to mark. For patients with negative node postoperatively or surgically or radiologically, the radiation volume should include the entity of the extrailiac, intrailiac, obturator, presacral, nodal basins. So you need to include these are the area where you may have nodal failure or nodal recurrence. You may have microscopic or submicroscopic disease. So that is why you need to treat this area. So in patients like paraotic involvement or if you are getting like this, I can tell you, suppose if you are getting a node positive here in the extrailiac or internal iliac, then you should contour up to the common iliac. If you are getting a common iliac node positive, then definitely you should include much higher extent. So that is why for a paraotic nodal radiation, when we give an extended field radiotherapy, when there is a paraotic nodal positivity on radiologically or a surgical sample, then we need to contour up to the level of the renal vessel. We should contour it. For patient lower 1/3 vaginal involvement, bilateral groin node should covered as well. So if somebody is having a low down disease involving the lower third of vagina, then you should contour the bilateral groin node also. So these are few of the things many a times in 2D we are doing, maybe many a times in 3D we are forgetting to do. Like by default, if you are treating in a cobalt unit, the FPPA portal is large field, you are treating the groin node. At the same time, while doing a IGRT and IMRT, you might be forgetting the area to treat in the groin, because earlier in the 2D one, by default you are treating. Now in a IGRT one, you want to do it in a more precise way. At the same time, you are leaving the part where you need to really give radiotherapy. So a few of my teachers used to tell the IMRT is one of the expensive way of sparing the disease rather than not sparing the normal tissue. So that is why if you really do not know what to treat or what to not to treat, you should not go for IMRT. You must know about it prior to that. So no, that is why we treat in that way. Sometimes what happened, we need to give more dose to the gross node, gross residual node, or sometimes we give more dose to the gross parametrial disease or residual disease. So there we can treat with a SIB treatment, simultaneous integrated boost, or sometimes we give a SBRT boost to the node. Maybe after completion or in between, we can give 10 gray or 5 gray SBRT boost to that one. Or we can treat like IMRT, SIB, all the area will get 1.8 gray per fraction. The real gross disease area will get 2.2 gray or 2.1 gray per fraction, so that by the time it gets 45 gray, the other area will get, the gross disease will get say around say 60 gray equivalent. Or maybe sometimes we treat an isolated metastatic site. We treat with a SBRT. You treat the whole pelvis along with the area like a IMRT or IGRT. Small metastatic area in a bone in a distant site may be treated with SBRT, or SBRT we treat to complete the treatment in a small time span, and maybe sometimes we get better result in such cases also. These are the contouring thing. Those who are radiation oncologists in the audience, maybe they know very well, much better than me. But at the same time, these are, you remember one thing, these are all guidelines that has been devised and that has been given. You have to take your own decision. Sometimes you need to modify according to the requirement of your patient. So that's very important also. But interesting thing is that you are treating very precisely to the target. At the same time, your another organ at risk is a moving organ at risk, or a organ at risk which changes its size with time. Like for example, bladder. If you look at the bladder filling, definitely the bladder filling is not same for all the 1.5 month radiotherapy. If you are giving, the bladder volume is not same while treating. At the same time, what happened while treating, go on increasing a dose of radiotherapy to the pelvic area or even to the bladder, what will happen? the bladder mucosa will become more inflamed. At the same time, evacuation will be more. So the size of the bladder over time, maybe first week of radiotherapy and the last week of radiotherapy, if you see, it's directly proportional to the dose. The size will shrink. So bladder filling will be less actually. So that's why we had certain women and me, we had a publication on that. What exactly the bladder size in relation to the week of radiotherapy. So that, in such cases, what happened actually, we try to give we try to give dose of radiotherapy to bladder so that we can look into the movement of the target, because with bladder filling, pardon, I'm sorry for the interruption. Yes, here you can see actually the PET based planning in a paraotic node. The SIB treatment 59 gray to the gross node and 50 gray to the surrounding area. This is the beauty of SIB IMRT. You can treat. So dose prescription, let us come to finish it in a very short time, maybe another 5-10 minutes. Dose you know very well. We give around microscopic disease 45-50 gray grossly. Gross adenopathy, we grade 10 to 15 or 20 gray extra, maybe by SBRT or SIB. So for definitive pelvic radiotherapy, for 45, average is around 45 gray we give. At the same time, rest of the dose we supplement by brachytherapy. So brachytherapy dose, if you see here, is around 30 to 40 gray. At the same time, the point A dose is around, say, more than 85 gray we try to keep. For early disease or small volume disease, maybe 75 to 80 gray we keep the point A dose. So point A dose is very important, because what exactly a point A dose is, I can tell you here. The point A is here. This is the area 2 centimeter above and 2 centimeter lateral. So this is the area. So by the time we get a dose of somehow around 80 or 85, at the same time your cervix or the disease area, the gross disease, the starting area is getting around much more than that, around 100-150 gray. So that's the beauty of brachytherapy, because there is a sharp fall off of dose, and these area, the cervix and this upper vagina, they tolerate, even tolerance is around 200 gray. So that is why we have set a historical point A dose around 80-85 gray in these cases. So by that only we can treat. But at the same time, the newer thing that has come up in brachytherapy, you can see here, the newer things are like image guided brachytherapy. So in image guided brachytherapy, what happened actually, while giving brachytherapy, precisely you are giving in the internal os and by the two overt to that cervical area. At the same time, you are keeping the point A dose fixed. At the same time, what happened, there is a much more inhomogeneity in the dose in brachytherapy, because the very high dose will be close to that to the source, closer to the source area. At the same time, you get a standard dose of around, say, total dose of around 85 gray at the point A. But if you are doing an image guidance, at the same time, the rectal dose and the bladder dose you can manipulate actually, because the anatomy of all the persons are not same. The anatomy or the size of the disease or the size of the uterus, size of the position of the cervix or uterus is not same for all patients. So in such cases actually, maybe you will find very nicely if you are doing under image guidance, so that it actually you can deliver more dose. At the same time, you will have less toxicity. Important is toxicity basically. So that is why we give that. Sometimes intraoperative radiotherapy we give. Sometimes we give a electron beam therapy in the operation theater, where the facilities are there, especially to those with the gross residual disease. So there what happened, what we do, you keep away the other viscera away from the target. At the same time, we give it then and there, maybe single dose of very high dose, around depends on the size of the residual, and at the same time whether he has received radiotherapy earlier or not, we do it in that way. So brachytherapy, let us discuss a 5 minute about brachytherapy only. We have intracavitary brachytherapy, we have a intravaginal brachytherapy, we have a interstitial implant or interstitial brachytherapy. But in a intracavitary brachytherapy, as I told you, point A is a very important area where we keep the dose of certain standard like 75 to 80 or 80 to 85. We keep in that area. These are the applicators, brachytherapy applicators. These are the two overhead. This is the central tendon inside the cervical canal, and here this is a ring applicator. Here these are the ring applicator with the central central area which can enter into the cervical canal. So these are applicator. These are the isodose. You can see here. This part is at the in external os, internal os. So in the os area, so from here 2 centimeter above and 2 centimeter lateral, the area we keep it around 85 gray total dose. At the same time, you can see here how the dose gradients are there. This is 100%, this is 80, 50, 40. The sharp fall off is there. So that is why by the time we get around 80, 85 gray here, here we get around 200 gray or 150 gray like this. So we get a very high dose there, and there to closer to the tendon. This is MR compatible applicator. This is used for the image guided brachytherapy. What happened? We take a MRI, we put the applicator, everything at making ready. We take the MRI of that area. We look into the bladder. We look into the bladder mucosa. Look into the rectal mucosa. At the same time, we optimize the dose to the bladder and the rectal mucosa. At the same time, we achieve maximum dose in the target or the area which needs to be treated. These are the treatment planning of this MR compatible applicator. Here you can see reconstruction of the applicator. So that's about that. And something like interstitial brachytherapy, you might have heard about the MUPIT implant. This is the one. This is the implant template. Here the metallic needles have been inserted in the perineal area. Here it is there in the vagina. At the same time, these are the area surrounding the parametrium or the anteriorly. You can see anteriorly there is nothing is there. Posteriorly also nothing is there. Anteriorly they spare the bladder. Posteriorly they spare the rectum. At the same time, these are the parametrial needles. So they put it, and the iridium source is put there. Then they calculate the dose and they get a resultant of this. This is the X-ray of this MUPIT implant. You can see it. If you look at it, it's really a very painful process, but we do it under general anesthesia in the OT. So we treat like that. After surgery, when we give a radiotherapy or brachytherapy to the vaginal vault, actually, we use a central cervical servo, a cylinder kind of thing put in the vagina. At the same time, we prescribe the dose 5 millimeter away from the surface, maybe around 5 gray into 2 or 5.5 into 2 or 6 gray into 3 dose. We give as a brachytherapy procedure. So there are multiple regimens of brachytherapy dose prescriptions, but the resultant, earlier we are using LDR, now we are using SDR, now we are using SDR with image guidance. So latest is image guided radiotherapy or brachytherapy, especially by MR guidance. So this is the one you can see here. These are the images, and these are the they reconstruct it. They look into the target. At the same time, they prescribe the dose accordingly. So MPET MR, I think image guided brachytherapy, they did a PET MR fusion and do. So this is all about the treatment, but important thing what I would like to tell you for this brachytherapy or the radiotherapy of the cancer cervix is early stage you operate. If you are thinking probably you need a radiotherapy, don't operate rather than giving a radical radiotherapy. Advanced stage, give radiotherapy with concurrent chemotherapy. The radiotherapy should be a IMRT or IGRT with a brachytherapy. Ideally, it should be image guided brachytherapy if possible, because you may get a cure the chances of cure is very high in these cases, like around, say, in a stage 3 also you'll get a survival of, say, 5 year survival around 70%. So you are going to cure the patient. At the same time, the patient will suffer throughout his life with rectal bleeding or the bladder or the hematuria. So these are the few very important toxicity which you need to do or need to manage during treatment, because they are late toxicity. It will appear after 3 year or 5 year. So if you have not treated properly in the beginning, then definitely you will end up with all these complications. So that is why cancer cervix treatment is very important. And as I discussed, maybe if you of the non-oncologists might be there in the audience, as I showed in the first slides, it is not discussed much, because if you discuss to the non-oncologist regarding the point A, point B dose and all these things, it's very difficult for them to understand also. So that is why people never discuss about it. So that's the very important. If you talk about breast cancer, people are going to listen to it. So that's what about the cancer cervix. Now, little bit about the prevention part. As you know, very important thing, pap smear you do, because this is one cancer, a pre-cancerous condition is there around a 5 year or for a 5 year or more than that, prior to disease starting of disease. So that is why when you are getting a pre-cancerous condition, you can go, or the early stage condition, then you can go for a pap smear test. You can check, you can do a survey, you can find out, yes, the one probably is having a early disease. So you can detect it much early if you can do a pap smear test. So that's why it's very important. And if you are like, very important thing is that please don't smoke, because again it has got an impact over cancer cervix, especially as I told you, the risk factor, multiple partner, HPV infection, all these things are there for the risk factor. That is why you need to take vaccination for HPV if eligible. And eligible is ideal, eligible age is not there. It is like this: prior to sexual exposure is the best, or sometimes we give around women of 19 to 26 years of age, maybe 13 to 18 years of age. So sometimes basically if you are not exposed to sex, then you should go for a cervical cancer vaccination. You should take, it will prevent definitely from that only. So so that's the reason what we need to do is this only. So after that, after all, I would like to tell or thanks the audience for kind listening of my talk. But the last one I would like to tell or thanks that this is a teamwork. It is not by one person. You need a surgeon, surgical gynecologist, gynecological oncosurgeons, or a good radiation oncologist. You need a good equipment for brachytherapy, good equipment for a IGRT. At the same time, you need a medical oncologist. You need a good pathologist who can give the proper report. It's a team effort. It's not a one-man job. So thank you very much for your kindness. And any question, maybe you can put.
Thank you so much, sir. Sir, is actually because of some government meetings, our moderator, Dr. SUSHIL Kumar Giri sir, is not being able to attend this
Okay,
webinar.
okay. So I can answer the question, no problem. If anybody have any question in the chat box.
We can go for a lot of questions, sir. Uh, okay, sir. One question we have received is extreme pain on the cervical area and pelvic bone during menstruation be a sign of cervical cancer?
See, pain is not linked with this disease at all. What happened when there is a parametrial disease, advanced cervical disease, it will enter into the lateral pelvic bone or the infiltrate the lateral pelvic wall and the pelvic bone, then you will have pain. But if you are having pain during menstruation, maybe you might be having fibroid uterus might be there. It may not be related to that actually.
So another question we have received is, can you tell a few lines about cervical cancer vaccine and its efficacy?
Yeah, efficacy is definitely there. there are three strains of things are there, vaccines are there, I think 16, 18, 19, or something, 19 or something like that. But it is definitely efficacious, there is no doubt about it. But at the same time, you should take it prior to exposure, sexual exposure. Because once there is sexual exposure, then possibility you might get infected. The moment you get infected, if you are taking vaccine, it is useless. It is not going to work. That's why it is a very short thing in my slide were there. So you can take this. I think there are polyvalent vaccines are available, quite efficacious.
Another question is, sir, if the patient has a stage 3 cervical cancer, what will be the percentage that the patient will survive, and what are the treatments to follow?
Yes. Interesting thing, whenever we are telling stage 3 cervical cancer, many a times people used to tell it was stage 3. So finally the patient didn't survive because we have not evaluated the patient properly. In a stage 3, straight away you should go for a PET CT scan to know about the status, whether really you are dealing with a stage 1 disease or stage 2 disease or stage 3 disease, or really it is a stage 4 disease. So that is why in a stage 3, if you are treating with CTRT, weekly cisplatin with radiotherapy followed by brachytherapy, we get a survival of around 70%, 60 to 70%, 5 year survival. So it's a good survival definitely. 10-year survival will drop down to another say 40% roughly. So you are going to get survival. These are curable diseases still.
So another question is, what is the best diagnostic test for cervical cancer?
See, that depends on the stage to stage actually. Earlier, if what happened, what we do is say if there is a frank growth, it is the biopsy that will give you answer. If there is a really very stage 1, A1, stage A1, A2, a very, very early disease, maybe these are the diseases you can catch up by colposcopy. Do a colposcopy guided biopsy will be the answer. So that's why so in an early stage, if you are doing a even PET scan also, you may not get anything there. You may miss it. Because it's a very small disease. So biopsy is the answer if you want to really know whether there is a cancer or not. If it is biopsy positive, then it is there. But again, in an early disease, it should be a colposcopy guided biopsy.
So we have received a question from YouTube as well. Sir, does a cyst in uterus lead to cervical cancer?
No, no, no. There is no link with that actually.
So one more question: is there any post-vaccination effect in the development of children?
See what happened. The post-vaccination, see, it never causes like earlier the live polio virus people used to give. No, the those who take the vaccine, they were having polio. It is not like so actually. It is not like that. The post-vaccination will be like other vaccine only. You will have certain fever, some dizziness will be there. Nothing is there. Other than that, nothing will be there. It is quite safe. Quite safe.
Okay, sir. So I think we have almost covered a lot of questions, sir. So, so before we end this, I would like to request our program director, Dr. Ghanshyam Biswas, sir, if you could please request to speak. We will invite him. Sir, could you please request? Dr. Ghanshyam Biswas, sir, could you please request to speak in the
Dr. Vishwas. Yeah, Dr. Biswas, please. He is online.
Yes, sir, okay, sir. I think we have almost covered up all the questions. So, so before we end this, sir, I'd like to tell everyone who are attending, who are watching us live, all the attendees. So, everyone will be receiving a mail through which you will be getting a link for the downloading of certificates as well as the feedback link. So, you need not worry about how, sir. Sir is requested to speak. We can accept.
Yeah, yeah.
I'm just accepted.
Yes, Dr. Vishwas. It's not audible.
Yes, I is joined.
Yes, Dr. Vishwas.
Thank you, Dr. Sanjeev, for a wonderful and such a elaborative talk. So I think cervical cancer is a very common world, and if you talk about India, with the rural population, so I think it is the most commonest cancer. So to all the female audiences, so menstrual hygiene is important, and we have seen that one of the Hindi movies, Padman, and there is also a lady from Western Odisha, that the Pad girl of India, Odisha. So who have been working really hard for the menstrual hygiene of especially rural population and those from the red light areas or the prostitutes. So I think so. This is a disease of a hygiene, and that is directly linked to a human papilloma virus, and that's the importance that this virus, as Dr. Sandeep said. So it's important once an individual girl is not exposed, sexually exposed, and before 25, probably that is the most beneficial, and actually it covers the high risk strain. So around 70% of these individuals are protected. So not 100%. So that's why it is more important to have all those preventive measures as what Dr. Sanjeev mentioned, and it is wise to have at least one pap smear in a lifetime to know. So at least are you having a predisposing conditions or early cancers. So it is one of those curable malignancies. And India is supposed to have three common cancers like cervical and breast cancer in females and oral cancers in males and females, and all are supposed to be a surface cancer. So where a bit of common sense can really make life more beautiful than miserable. And unfortunately, in spite of all awarenesses and so be it the urban population, rural population, we still these three common cancers are still almost two-thirds of the population seen in advanced cancer, and where so the misery starts and hell lot of scientific information treatment is needed. So I think the importance of such talk and such cancers are that it should go into the common masses and everybody should understand. So be aware. Today we are aware of corona infection, which has come only 6 months, and we are talking about diseases which is there for ages. So I think it's time that we should take care of ourselves and be healthy. And thank you, Ashish, again, once again. And so we'll be continuing our endeavor in this journey of webinar with BioLeaks. So by this we completed sixth episode, and next Saturday we are again meeting at the same time. So next time we'll be meeting another cancer, that is cancer of pancreas, and we know that in last few years many celebrities and many important figures in the country and abroad have lost their life because of this cancer. So this is one of the hard disease to treat in terms of unless and until surgery is possible. So we'll focus on pancreatic cancer. So next week, that is 29th September, 3:30 to 4:30, and so that will be first time a sponsored session on this platform from the AstraZeneca team. So till then, so from India, so this is Ganesh Chaturthi, and I wish everybody good health, prosperity, and they should stay away from COVID at this point of time. Over to
Thank you
Ashish.
so much. Thank you so much, sir, for your beautiful summary at the end. So before we end, I would again like to say, as sir said, the next week we are again going to conduct a webinar at the same time in the same platform. The name of the webinar would be Updates in the Management of Pancreatic Cancer, and that would be a sponsored webinar. It would be supported by AstraZeneca, as sir said. So stay tuned to our Facebook page, to our YouTube channel, and as I can say that already more than 100 people have already registered for the 29th August webinar. So we would all the registrants who have registered for the webinar will be receiving an email shortly with the certificate downloading link as well as the feedback link for the same webinar and the registration link for the next webinar as well. So till then, I would like to thank Dr. Sanjeev Mishra sir for the beautiful and informative session. And I would also like to thank Dr. Ghanshyam Biswas sir, our program director, for helping us in organizing such beautiful webinars as well. Thank you so much, sir. And we are sure that we'll be coming up with more beautiful webinars in the near future. Thank you. Thank you so much, sir. Thank you, sir.
Thank you. Okay.